Assalamu alaikum. In the previous lecture, we were studying the different contraceptive methods which are being used, and we did the barrier methods, and we were studying the intrauterine devices. And we'll continue with the intrauterine devices. Now, IUDs have many advantages. That number one, it's very simple. Like no complex procedures are involved in insertion, no hospitalization is required after the insertion. And insertion takes only a few minutes and it's inexpensive and the contraceptive effect is reversible. And usually there are no metabolic side effects as well. Now, certain contraindications of IUCD usage are also seen. There are absolute contraindications and relative contraindications. In absolute contraindications of IUCD usage, the conditions are suspected pregnancy, if there is pelvic inflammatory disease, or if there is vaginal bleeding of undiagnosed etiology, cancer of cervix, uterus, or adnexia, or any other pelvic tumors, or if there is any previous history of ectopic pregnancy. The relative contraindications of IUCD usage are number one, if the female is anemic, or there is history of menorrhagia or any history of pelvic inflammatory disease since her last pregnancy, or there is purulent cervical discharge, and if there is distortion of the uterine cavity due to any congenital malformations, or if there are any fibroids, or if the female is a unmotivated client. Now, the Planned Parenthood Federation of America has described the IUCD candidate as the one who has at least one child. There is no history of pelvic inflammatory disease. The menstrual periods are normal and she is willing to check the IUCD tail and has access to follow-up and treatment and is in a monogamous relationship. Now, the most appropriate time for the insertion of IUCD is during the menstrual period or within 10 days of the beginning of the menstrual period. Now, during this time, the insertion is technically easy as the diameter of the cervical canal is greater. The uterus is relaxed and there are less myometrial contractions during this period, so the rate of expulsion is very less. And IUCD insertion can also be done during the first week after delivery of the that is your immediate postpartum insertion, but this is very risky as there can be perforation of the uterus during insertion, and there can be expulsion of the IUCD as well. So the convenient time is usually the post perpural insertion, that is during the perpural, that is 6 to 8 weeks after delivery. Now, an important aspect of IUCD insertion is follow-up, which is usually neglected. And the objectives of the follow-up examination are to provide motivation and emotional support to the female and to confirm the presence of IUCD and diagnose and treat any side effects or complications which the female is feeling. Now, the IUCD wearer should be examined after her first menstrual period and after her third menstrual period, and then at 6 month or 1 year interval of IUCD insertion, depending upon the facilities and the convenience of that person. Now, what instructions you should give to the IUCD wearer? That she should regularly check the thread or tail of the IUCD, and if she fails to locate that thread, she should come to the doctor. And she should visit the clinic whenever she feels any side effects like fever, pelvic pain, or bleeding, or she misses a period as well. IUCD insertion can cause certain side effects and complications. The most commonest is increased vaginal bleeding. It only accounts for 10 to 20% of all IUCD removals. There can be increased volume of blood loss during the menstrual period, or the menstrual period can prolong, or there can be mid-cycle bleeding. Usually this settles down within 1 to 2 months, or if it prolongs in certain cases, then IUCD can be removed. Now the copper devices usually cause less average blood loss, and menstrual blood loss is lower when hormone releasing devices are used, like Mirena. Now, second side effect is pain. Pain is usually felt in 15 to 40% of IUCD removals, and pain can be in the lower abdominal area, or there can be lower backache, or it can be down the thighs. Now, this is very less, and it can be due to certain infection which is caused by IUCD, or disparity in the size between the device and the uterine cavity. Now, another side effect is pelvic infection, or pelvic inflammatory disease is a collective term which includes infection in the uterus, your ovary, fallopian tubes, or connective tissue, and the pelvic peritoneum. And it can be due to if a woman has more sexual partners, or if during insertion sterilization was not taken into account, or there can be ascending infection from the lower genital tract to the uterus, and which ascends to the tubes, and so on. Now the clinical signs or symptoms of infection, as you know, there can be vaginal discharge, there can be pelvic pain, tenderness, or abnormal bleeding, and high-grade fever. Usually this responds well to broad-spectrum antibiotics, but if more than 1 or 2 episodes occur, it should be removed because it can lead to infertility or permanently blocking of the fallopian tubes. Now, another complication is uterine perforation. The reported incidence is from 1 to 150 to 1:9,000 insertions, which depends upon the time of insertion of IUCD and the design of IUCD, the technique of insertion, and who has inserted the IUCD. Usually it should be done by a trained personnel. Now the device can migrate into the peritoneal cavity, causing complications like intestinal obstructions. Now, next complication or side effect is usually pregnancy. It only occurs in around 3% of the cases. Now, pregnancies with an IUCD can lead to certain medical complications, like it can lead to infections and spontaneous abortions. Now, only 25% of the pregnancies will have a successful outcome if the IUCD is left in place. Now, another side effect is that ectopic pregnancy can occur, and it usually occurs when IUCD user becomes pregnant. There usually is a possibility of ectopic pregnancy. Now, the ectopic pregnancy rate per 1,000 women year in levonorgestrel IUCD and copper-T is about 0.2 as compared to a non-contraceptive user. Now, usually the less complications or the side effects are expulsion of the intrauterine device, which can be partial or complete, or after removal of the IUCD, 70% of the users usually conceive within 1 year of stopping the use of IUCD. Now, there is no evidence to date that IUCD cause cancer risk and mortality. associated with IUCD is very rare, and it is usually associated with some complications such as septic spontaneous abortion or ectopic pregnancy. First, we did the barrier methods and then the intrauterine devices. Now, coming to the hormonal contraceptives. Now, the hormonal contraceptives, they have two types of hormones, estrogens or progestogens, or a combination of both. And it is usually classified as oral pills. Oral pills, they can be in the form of combined pills, which are known as COPs, progesterone only pills, which are called POPs, postcoital pills, once a month pill, which is a long acting pill, or male pills. And another type of hormonal contraceptives are your depot formulations or slow release formulations, which are in the form of injections or subcutaneous implants or vaginal rings. The combined oral contraceptive pills, or your COPs, were introduced in early 1960s, but the dose of estrogen and progestogen in those tablets was high. So now at present, the current formulation has synthetic estrogen, which is 30 to 35 microgram, and progestogen is 0.5 to 1 milligram. Now, the pill is given orally for 21 consecutive days, beginning on the 5th day of the menstrual cycle. As you can see in the blister pack, which is shown in this picture, there are 28 tablets. The 21 white tablets are your COPs, and the red ones are the iron preparations. Now, after the 21 days, there is a break of 7 days, during which withdrawal bleeding occur. Now, these 7 tablets of iron are continued in those days, so that you don't break the habit of taking a tablet daily. And the pill should be taken every day at a fixed time, preferably it is said that before going to bed at night. And the first course should be started, as I told you, on the 5th day of the menstrual period. So if the user forgets to take a pill, then she should take as soon as she remembers, and then she should take the next pill accordingly at the usual time. The progestogen only pill, or your POPs, are also called mini pills or micro pills. They contain progestogen, which is given in small doses throughout the menstrual cycle, and two types of progestogens are used, norethisterone and levonorgestrel. They can be given in older women in whom combined oral contraceptive pills are contraindicated because of cardiovascular risks, and it can also be given in younger women with risk factors for neoplasia. Now, the mechanism of action of oral pills is that in combined oral pills, they usually prevent the release of ovum from the ovary, and this is usually achieved by blocking the pituitary secretion of gonadotropin, which is required for ovulation. Now, the POP preparation, they make the cervical mucus thick and scanty, and therefore inhibit the sperm penetration. And they also inhibit tubal motility and delay the transport of sperm and of the ovum to the uterine cavity. Postcoital contraception is recommended within 72 hours of unprotected intercourse. It is usually done by two methods: by IUCD insertion, especially a copper device, within 5 days, or it can be done by hormonal method. For this, levonorgestrel 0.75 milligram tablet is approved, and it is used as one tablet given within 72 hours of unprotected sex, and the second tablet to be given after 12 hours of the second dose. Before you prescribe oral contraceptives, there is checklist for the prescription of oral contraceptives, and you should take history and do examination like you should ask if that female is above 40 years of age, or if she is above 35, or she is a heavy smoker, or is there any history of seizures, pain in the calves or thighs, there is symptomatic varicose veins in the legs, any history of chest pain, unusual shortness of breath after examination, or there is history of severe headache, migraines, or visual disturbances. If the mother is breastfeeding her younger child, if yes, for how long? And is there any history of intramenstrual bleeding or bleeding after sexual intercourse? Any history of amenorrhea, abnormally yellow skin, eyes? You should take the blood pressure. And if any history of hypertension, is there any mass in the breast, and any swollen legs like edema in the legs or feet? Now, if all these things are negative, then the woman you can prescribe oral contraceptives. Or if anything is positive in the checklist, then you have to ask the doctor, and then these oral contraceptives can be prescribed. Now, there are certain contraindications in which you cannot give these oral contraceptives. Like oral absolute contraindications are CA breast or genitals, any liver disease, previous or present history of thromboembolism, is if there is any history of any cardiac abnormality or congenital hyperlipidemia or undiagnosed abnormal uterine bleeding. Now, in special problems which require medical surveillance are if the female is above 40 years of age, or if she is 35 years of age and smokes. There is any history of mild hypertension, chronic renal disease, any history of seizures like epilepsy, any history of migraine or a nursing mother in the first 6 months, diabetes mellitus, or gallbladder disease, or amenorrhea, etc. So these are the relative sort of contraindications in which you should consult, and then you should proceed with the oral contraceptives if they are allowed. There are certain side effects related to the usage of oral contraceptives. It was said earlier that cardiovascular incidents like myocardial infarction, cerebral thrombosis, or venous thrombosis was more with the oral contraceptive usage. But now, as the time passes, the estrogen and progesterone content has been reduced in the oral contraceptives, so chances are very less of getting any cardiovascular abnormality. But if the female is above 35 years of age and she's a smoker, then chances of getting cardiovascular risks are more. Now coming to the lactating mothers, if she wants to get a contraceptive pill, then progesterone only pills are advised in lactating mothers, as they do not affect the quantity and constituents of the breast milk as compared to the COPs. Now, subsequent fertility, the contraceptives, it is usually said, there's a myth that after usage of contraceptive pills, fertility cannot be resumed, but usually it is seen that after discontinuing the usage, even after 2 months, the female can get pregnant. So this is just a myth. So fetal development is also normal after discontinuation of the oral contraceptive. So no abnormality has been seen so far. Now, ectopic pregnancy can occur in those clients who use progesterone only pills, but usually the chances are very less. Now, those females who suffer from liver disorders, they should also be very carefully prescribe these pills, as these pills can more aggravate these liver disorders. And there are certain metabolic effects, like these pills can elevate the blood pressure, and they can also alter the serum lipid levels. And there are others unwanted side effects, like there can be breast tenderness. A female can gain weight which is above around about 2 kgs. There can be history of headache, migraine, and bleeding disturbances can also occur.